morning, everyone. Yesterday, I was talking about bloat in large ruminants. So, I was supposed to do two sessions. One was on bloat, another was on increasing the survivability after cesarean section in large ruminants. Coming to the reticular causes. About bloat, yesterday I covered about esophageal causes and ruminal causes. Third one is the reticular causes. This is one of the important cause which leads to bloat in large ruminants. What all are the different reticular causes? So that is, there are so many conditions. I listed all the conditions here. I will explain one by one. First one is the traumatic reticulitis or reticular abscess. Whenever a foreign body, any sharp foreign body is ingested by the large ruminant, by cow or buffalo, it will go to the rumen and it will just settle in the rumen. It will not harm it will not harm the animal. While digestion process is going on, that sharp foreign body will move to reticulum. As we know the anatomy, the rumen will be wide open and the opening into the reticulum is also wide open. So whatever the foreign body ingested will enter the reticulum, and from the reticulum to omasum only this much will be the opening. Only 2 fingers can enter. So any sharp foreign body which is taken by the animal or any large amount of plastic or some foreign bodies, whichever taken by the animal, will stay only in the reticulum. For years together, they will stay only in the reticulum. So, while the food is moving from the rumen to the reticulum, once it enters the reticulum, it will stay in the reticulum. So, while the reticular contractions are happening in 1 or 2 days or in 1 week or 1 month, at any one time, whenever the reticulum is contracting, the sharp foreign body pierces the reticulum. Whenever the sharp foreign body pierces the reticulum, so it leads to inflammation. Local inflammation will occur. So that may lead to the formation of abscess, or that may lead to inflammation. So at that point of place, the reticulum will adhere to the surrounding abdominal wall. So there will be adhesions. Because of these adhesions, reticulum cannot contract. So because of this, whatever the gases produced in the rumen and reticulum will not erect out because of the non-contractility of the reticulum. That will lead to traumatic reticulitis. So this is the pathogenesis of traumatic reticulitis. So here the foreign body is piercing only the reticular wall and it is not coming out. Once it comes out of the reticulum, there will be development of peritonitis. So here only I am explaining about the traumatic reticulitis case. So what will be the symptoms? How the animal will be presented to us is, the history will be not severe bloat will be there in traumatic reticulitis. The history will be the animal will always looks like with distended abdomen. Not the huge abdomen like this. Even though animal is not taking anything, the stomach looks like filled. It is filled completely. Like that it will be always. So that is the one thing. Second thing is the animal will show some part of lameness, and always we should open the dung and examine. If we see this pic, the dung looks normal. So once we open it, we will see the undigested fibrous particle in that dung. So this is one of the important sign of the reticular affections. In that particular case, there was sharp foreign body piercing into the reticulum and it was adhered to the abdomen. Because of that, there was recurrent tympani. So this was a case of traumatic reticulitis which was operated. And this case was a pregnant animal, around 3 months pregnant when operated, and the animal coughed normal cough after the surgery. This is on the day 0 we can see fibrous particles. On day 4 the normal dung is there. So this is the traumatic reticulitis. This is after recovery. After 20 days I took the photography. So the traumatic reticulitis, this is another case. We can see that there is dehydration. Whenever there is traumatic reticulitis, there will be slight dehydration. Whenever it is advanced, that led to traumatic reticuloperitonitis, means the foreign body has entered the reticulum and it has came out into the abdomen where there is peritonitis development. So there will be more toxemia. So there will be more temperature and there will be severe dehydration. In this pic we can see it is a moderate dehydration. This was also a 3-month pregnant animal. So the history of the animal was, it was showing severe lameness, the colic pain while standing, and there was recurrent tympani. That means I already explained that not too much distension of the abdomen. The abdomen used to always looks like completely filled, even though animal was not taking anything. So the owner sent this video, undigested feed particles in the dung and animal showing colic pain with the always distended abdomen and moderate dehydration. We planned ruminotomy. In this case, the traumatic reticulitis was happened because of the sharp foreign body which pierced through the reticulum, and the reticulum was adhered and there was a foreign body. We should search it in the reticulum and we should remove it. So antibiotics should be continued for minimum 10 days, and the adhesions will be cleared automatically after some days. So this was a case of traumatic reticuloperitonitis. How we can double the farmer's income through the surgeries? This case was presented to me around 2 years back. So that animal was pregnant, 3 months pregnant. So animal delivered normal calf after completing 9 months, and now it's almost 2 years. You can see in this peak, the animal was pregnant when I was operated this case. It gave birth to this animal. Now after 2 years, this animal is 3 months pregnant. This animal once again gave birth to another calf. Like this, we can double the farmer's income through the surgeries and even by the treatment. So this was a case of a disease. Animal is a very huge yielder. It is giving around 20 liters milk per time. And this is another case of traumatic reticulitis with a sharp foreign body. These will just struck in the reticulum. They will not come out. So we can see these are the very small foreign bodies, but sharp. They will induce the inflammation in the reticulum. It was a case presented with a recurrent bloat. So I removed all the foreign bodies, sharp foreign from the reticulum. This animal recovered very well. In this particular case, it was a recurrent tympani case. I operated it, but there was no foreign bodies. But examination revealed that after the reticulum, we will enter the omesum. Only 2 fingers can enter the omesum. So at the entrance between the reticulum and the omesal wall, there was a big abscess. So we can feel just like idli. This will comes with the experience. Every time when we are doing the exploration, we should examine all the parts. We should feel the consistency. Once we get the differences, easily we can identify it. There was a developing abscess. Just to confirm, I aspirated it from the ruminotomy site itself. So here we can see I aspirated the fluid from it. It is not a peritoneal fluid. This was aspirated from the abscess. This was an immature abscess. So after the surgery, animal gave birth to a normal calf and this recovered. Antibiotic was continued up to 15 days in this particular case. So these all are the things which lead to traumatic reticulitis. So how we will recognize it? In traumatic reticulitis, there will be fluctuating temperature. Whenever the foreign body pierces, there will be inflammation that will lead to temperature. Second thing is always the dung shows undigested feed particles. Third thing is moderate to severe distension of the rumen, and no fluid upon when we do cranial abdominocentesis, no fluids will be seen, as like in traumatic reticuloperitonitis where we will get huge quantity of fluids. So by all these, we can tentatively diagnose the case as traumatic reticulitis and go for the surgery. So coming to the management, ruminotomy and removal of the foreign body and long duration antibiotics. This is about traumatic reticulitis. Now I am moving on to traumatic reticuloperitonitis, an advanced stage. That is, the foreign body just piercing into the reticulum will enter the abdominal cavity. So when we are doing surgery, just I open the left flank, we can see the peritoneal fluid is there. This is not normal. Peritoneal fluid will be very less. And when we gave incision, before opening the rumen itself, huge quantity of peritoneal fluid is there. This indicates that there is a peritonitis. So that may be localized or generalized peritonitis. So there will be severe dehydration because of toxemia. And there will be rapid going down in the condition of the animal. So there will be huge quantity of fluid drains when we do cranial abdominocentesis. So in this particular case, I will just explain with the case. This was a pregnant animal of 9-month pregnancy with the distended abdomen. The history is always the animal looks like bloated. No severe enlargement, but always the animal looks like enlarged. So we can see severe dehydration, sunken eyeballs and periorbital fat lysis. The animal was making some sound, grunting sounds too. So I am showing the severe dehydration which happened in traumatic reticuloperitonitis. We can differentiate it from reticulitis and reticuloperitonitis. So in this case, there was grunting sounds were there. I actually muted the audio. Grunting sounds were also audible. So I did surgery on this animal, left flank laparotomy, ruminotomy and removal of the foreign body. So coming to the surgery, we operated it and I searched all the reticulum, but there was no foreign body. So what we should do? After searching the reticulum, we should hold the reticulum and we should just pull it. If it is freely moving, there will be definitely no problem with the reticulum. If there are some adhesions, when we pull the reticulum, it will be adhered to somewhere. So it will not come easily at reticulum. So that is the point where we should search for the foreign bodies. In this case, I searched it on the ventral aspect, it was adhered. So I went there and searched each and every honeycomb structures. There was a piercing foreign body. I removed it. After closing the ruminotomy site, I entered once again abdomen from the outer end of the rumen. I searched there for the adhesions. These were the adhesions. These were the adhesions, were foul smelling. and this is the fibrin deposits. If we see this during any laparotomies, that indicates that there is inflammation that led to the accumulation of the fibrin material. This is the fibrin material, and this is the necrosed material, adhered material, and they just removed it, and this is the foreign body rusted iron wire. And the dung, when presented, it will be dry with the coarse material, undigested material. So this was a pregnant animal. After that, in order to manage the peritonitis, we should use large quantity of normal saline. So I was not suspected when I was visiting that space. It was a night time around 11 o'clock when I was operating. Because of lack of the fluids, I used RO water. I used it in more than 80 to 100 animals, but I have no literature to say it is safe. Even then, I am not advising RO water to anyone, but in my practice I am regularly using it for flushing the abdomen. So I used around 30 liters of RO water to flush the abdomen. So in order to take it, I placed one Foley's catheter. So the animal recovered very well with the local peritonitis. Animal delivered a normal cough, and now also animal is living a happy life. This surgery was done around 4 years back. So that is the dehydration. This is after the surgery. So that is the dung presented. This is after the 18 days. So this is how the traumatic reticuloperitonitis. So this is about cranial abdominocentesis. How to identify? So when the animal is standing, from the xiphoid, we should come 10 centimeter back, comes 10 centimeter left side. So there just insert one needle, that is 18 gauge needle. We will get huge quantity of fluid. Normally we will get around 5 to 10 ml. But if we get huge quantity of fluids, it indicates that there is peritonitis. So this will be the diagnostic criteria during traumatic reticuloperitonitis. So this was a case presented, and this is about when the foreign body pierces from the reticulum ventrally. I am showing one case where the foreign body entered ventrally. This was a buffalo. This was also a 8-month pregnant animal. There was some abscess on the ventral aspect of the body, and it opened. I examined one very small foreign body end is there. Tip of the spoon was there. So in order to remove it, I had only two options. One is incising the area and removing the spoon. But this is a difficult task. Since head of the spoon was in the reticulum, only the tail end was outside the reticulum. So I incised and I extended the incision, and this was piercing the xiphoid and coming out, the spoon. So I removed it, I pulled the reticulum, I sutured the reticulum, and after that there was dung particles in the abdomen. So in order to manage that, I flushed it. I did surgery closure, and I placed one Foley's catheter for drainage. This is important thing whenever we suspect the peritonitis. I kept one Foley's catheter there, and this animal calved normally after 1 month, and this animal gave birth to 3 calves in subsequent yields. So this is a pic showing this also surgery was done around 4 years back. This is the animal, this is the first calf, and this is the second calf. Still now animal is living a happy life, and I approach it through the ventral aspect. Another approach for this particular case is doing the ruminotomy and removing the foreign body through the reticulum. We can do that also. So when foreign body pierces right laterally, this is about when the foreign body in the reticulum pierces out ventrally. When it comes to the right side, what may happen? In the rumen, as we know anatomy of the animal, if it is a rumen, on the left side spleen will be there. From middle to the right, up to right flank, that liver will be there. So animal, if it pierces right side, it may lead to abscess in the liver, or it may come out of the body. So here is a one case where the foreign body came out of the body on the right side. So this is an abscess just behind the elbow point on the right side. I ripened it with the counter irritants. After that, a sieving needle was took out from that area, and this is after recovery. The animal recovered very well. So like this also foreign body can come out from the right side of the body. This is a lucky animal, so this saved since it came out through the right side. So when foreign body pierces out from the reticulum cranially, that is the dangerous thing, as we all know, that will lead to traumatic pericarditis, traumatic diaphragmatic hernia, or pleurisy. I will go through them quickly with these 3 cases. Coming to pericarditis, as we all know, there will be traumatic pericarditis. Whenever the foreign body pierces from the pierces out of reticulum, it touches the diaphragm. So in case of buffaloes, the phrenic portion of diaphragm is very weak. When the foreign body touches the diaphragm, it will tear the diaphragm and it will lead to diaphragmatic hernia. In case of cattle, the phrenic portion is somewhat stronger. The foreign body pierces into the pericardium. It may lead to traumatic pericarditis. Even in buffaloes also traumatic pericarditis can occur. These are all the possibilities. Even in cattle also diaphragmatic hernia can occur. So this is the classical signs of traumatic pericarditis. First, initially when the foreign body pierces through the reticulum, there will be bloat for 1 day. After that bloat will subside, the other signs will develop. So this is jugular vein pulsation, submandibular edema, the brisket edema, all are the different signs of traumatic pericarditis. So after this this is the venous stasis test. So this was a animal presented with, this is the venous stasis test showing the bulging on the both cranial and caudal aspect of the jugular vein. That indicates that there is some heart involvement. From that we can easily identify it is a case related to heart. So the animal may go to recumbency too. So we should do simple test to 100% diagnose the pericarditis is pericardiocentesis. Just you do the auscultation, we will hear so many different types of sounds. One thing is the water flowing through the pipe, that is called as fluid splashing sound. In sometimes we will get muffled heart sound. If we are confusing, then just insert 2 ml needle, after aseptically withdraw it, we will get some fluid. So normally we will get around 1 or 2 ml of fluid. If it is more than that and if it is foul smelling, it indicates that there is definitely traumatic pericarditis. So this cough was presented to me. I withdraw the blood and the scent, but immediately animal went to recumbency. So I did tube pericardiostomy. So I will just explain the tube pericardiostomy technique in next few slides. So simple techniques which can be adopted under the field conditions. So this was the animal presented to me with the jugular vein pulsation, and all the signs of traumatic pericarditis were there. And the pericardiocentesis indicated the foul smelling discharge from the animal went to recumbency. Foul smelling content was aspirated, and TLC was 44,000 with the neutrophilia. So I did just inserted on 2 ml syringe, and normal 23 gauge needle is enough for doing pericardiocentesis. So it was concluded as pericarditis, and a Foley's catheter was introduced into the pericardium. So I used Yagan stillet for introducing the Foley's catheter into the pericardium. So the fluid will gush out. So I did perform this procedure in more than around 40 to 50 cases. Success rate is only 3 cases recovered. That will be there. That much lesser success rate is there. But even then, we can survive the animals if the owner is ready. We can take chances. So in this particular calf was recovered. So around 2 liters of fluid. In my service, I recovered up to 8 liters of fluid from different animals. That is the maximum content which I recovered. So in this case, around 3 liters of suppurative fluid was removed from the Foley's catheter. So Foley's catheter was placed into the pericardium. I am lavaging the pericardial area with the metronidazole and normal saline. So here I lavaged it. After this, the animal will be stabilized, so that brisket edema will subside. After that, the next day we can go with the surgery for ruminotomy for removal of the foreign body. If the foreign body is still sticking in the reticulum, we can easily remove it. In this particular case, there was 2 sharp foreign bodies in the reticulum. We removed it, and after that I did pericardio lavaging for 10 days. So this animal recovered very well. I will just forward it because of the time constraint. So this is the animal which was operated with the ruminotomy. These were the sharp foreign bodies, and Foley's catheter was removed on day 5. After removing the Foley's catheter, also around 2 liters of fluid came out. That means the Foley's catheter was blocked. That is the biggest challenge we faced during encountering in these particular cases. So around 2 liters fluid once again came out. I inserted once again another Foley's catheter, and it was kept for another 2 to 3 days. After that, the submandibular edema, brisket edema, everything reduced. So this is on the 7th day. There was once again there was accumulation. There was recurrence. So I inserted another Foley's catheter and removed all the content. Luckily, this animal saved. What I want to tell you here is all the cases with traumatic pericarditis cannot be saved. So there will be guarded prognosis. But when we do it, there may be around 3 to 4 animals may survive out of 50 animals. That is the chances. If the owner is really ready, we can go with this procedure. Otherwise, as yesterday sir told, Vijay sir told like that, if the animal is pregnant for 8 months, we can extend the life of the animal for another one month, and the calf can be live its life. Otherwise, even we will lose both calf and the dam. So this is after the surgery. The animal recovered very well. So this is after around 8 months. I took the video of the same animal after the recovery with the traumatic pericarditis. So this is how we should do the pericardiocentesis. First, you should do auscultate both the sides of the abdomen, left and right side. you will where you will get more sounds, you take the animal to that side. So here right side was more sounds was there. I did pericardiosynthesis. So after auscultation clearly, so foul smelling discharge was there. So I placed one Foley's catheter. How to place the Foley's catheter? So first shave the area for 1 inch and you give local anesthesia for about 2 to 5 ml locally skin onto the muscles. Then take a Foley's catheter and the stillet of the AA gun. So just pass it. Why we are using stillet here is the Foley's catheter is flexible. We cannot introduce into the heart. So just to make it stiff, I am using the stillet, and after that giving the anesthesia, I am just giving a nick incision at that site. On the right side I am doing this procedure. Usually at the 5th intercostal space we will get more sound. So I am just incising, giving a nick incision there, and I am introducing the Foley's catheter with the stillet into the pericardium. Once we enter the pericardium, we will get a sound. We will feel it when the person we are doing, we will feel it. So we can introduce that Foley's catheter into the heart, that pericardium, and we can remove the stillet and we can inflate the Foley's catheter. If anyone having doubt in this procedure, I will share the videos with you, and I will even discuss with the same thing with you all. So after placing this Foley's catheter, there will be drainage. So every day we can flush it with the NS and metronidazole, and it should stay there for minimum 12 days. Since there will be repeated accumulation of the pericardial fluid, it should stay. So many research are happening since last decade about this. So many different catheters are used by many in the colleges too. So I used 16 number Foley's catheter. So immediately once we enter the pericardium, the foul smelling fluid will come out. So normally the heart will be surrounded by pericardium. There will be no much space between the pericardium and heart. But whenever this fluid is accumulated, the pericardium will be bulged. It will come near to the thorax, the rib cage. Just if we introduce 2 ml syringe, we will enter that pericardium. Easily we can withdraw it. Because of that only we can diagnose the pericarditis. So one limitation is there may be blockage of the Foley's catheter post-surgically. This is one complication. So here I applied the Foley's catheter since there was a blockage. So another thing is sometimes faulty Foley's catheter if we introduce. So if there is obstruction, then we can push it 20 ml of normal saline to clear it. This is a faulty Foley's catheter. It was in a cow which was presented with a sieving needle. Surgery was very nicely done, but that animal died because of the faulty Foley's catheter. We cannot introduce into the same space at the second attempt. That is the problem. So these are the different foreign bodies which were taken out by the different animals. This was a case presented which it is after recovery. After 7 days there was no brisket edema for anything is there, but I didn't found foreign body in the reticulum. It was already entered the thoracic cavity. That is one of the constraints. So animal died. This is on the postmortem. You remove this foreign body from the thorax. We can go with the thoracotomy, but even then we can save the animal life for another 1 or 2 months only. This is about pericarditis, and I am just going a bit faster because of the time constraint. If any doubts are there, I will clear it afterwards. When foreign body pierces deep into the heart, what happens? This is pericardium is just the outer layer covering of the heart, just like shirt. It is just outer covering. When the foreign body enters the heart, what happens is that will lead to endocarditis. I had one case of endocarditis. I will just show. This animal was presented to me in recumbency with all the signs of pericarditis. So there was brisket edema, jowl edema, there was everything was there. I did pericardiostomy, I removed the fluid, I did ruminotomy, I removed the foreign body from the reticulum. Everything was nice. So I thought animal was recovered, and after 1 month the animal recovered very well. This is after 1 month. Animal was living a happy life. But after that, once again there was recurrence of the submandibular edema, brisket edema, and jugular vein pulsation. So animal went to recumbency with severe anemia. I did thoracotomy also for this particular case, but animal died on the spot because of the severe anemia. So we did postmortem. We can see in the heart, in the one ventricle, the normal things can be seen. I will just show. In another one, we can see vegetative growth at the tricuspid valve. At the valve, there was severe vegetative growth. I will just incise it and show. So this is the normal ventricle, and this is another ventricle with the vegetative growth at the tricuspid valve. So this was a case of endocarditis caused by the sharp foreign body. So this is about traumatic pericarditis and endocarditis. Coming to the pleurisy, this also can be diagnosed near to the accuracy under field condition. So whenever foreign body pierces, when it touches the pericardium, it will lead to pericarditis. When it touches into the endocardium, it may lead to endocarditis. When it touches the pleura or pleural cavity or lungs, it may lead to accumulation of the fluid in the pleural cavity. So this is one case where there was traumatic pericarditis along with the pleurisy. So this was a case presented that very late after onset, or after around 10 days it was presented to me with severe swollen face, eyelids and everything. This is pericardicentesis indicating the pus, that is a suppurative fluid, and at the 5th intercostal space. So in the same case I did thoracocentesis. This is at the 7th intercostal space, not the 5th one. This is the 7th one. I am counting from the last 13 ribs will be there. From counting from the last 12th intercostal, 10th, 9th, like that. This is the 7th one, at where I am finding the fluid. So that is indicating that fluid is accumulated in the thoracic cavity. So I placed 2 Foley's catheter, one at the 7th and one at the 5th. So this is the suppurative fluid which was recovered from the pericardium, and this is from the pleurisy. So like that we can diagnose it. So even then the prognosis is guarded. In some cases we may see recovery in pleurisy too. Just placing a Foley's catheter at the 7th intercostal space and treating with antibiotics will cure the pleurisy. And coming to the diaphragmatic hernia, whenever foreign body pierces into the diaphragm, and this is a diaphragmatic hernia when I seen in the postmortem in buffalo. So this was a clinical case. What are the signs of diaphragmatic hernia? We can identify the diaphragmatic hernia easily by some of the classical clinical signs. I will just show my experiences. This was a case of recurrent bloat. Any case of buffalo with the recurrent bloat, first suspicion should be diaphragmatic hernia, since phrenic portion will be very weak in buffaloes. So it may lead to diaphragmatic hernia in buffaloes. More chances are there. This is a cattle. This was presented with severe bloat. Recurrent bloat is one of the classical sign of the diaphragmatic hernia. So this is a cow with recurrent bloat, and open mouth breathing at the later stages will be there. Open mouth breathing can be seen in case of last stages. This buffalo was sent to me. First the doctor called me. I told that it may be a case of diaphragmatic hernia because of the recurrent bloat. But owner didn't turn up for the surgery. After 15 days he turned up for surgery. When we went there, already prognosis was very guarded. Open mouth breathing and recurrent bloat was there. So this is a buffalo case. We did ruminotomy, but animal succumbed. So regurgitation in the last stages. Regurgitation in buffalo, one of the main thing we should think is diaphragmatic hernia. The recurrent bloat with the regurgitation in the buffaloes, more chances of diaphragmatic hernia. So characteristic frothy contents, ruminal contents will be seen during the ruminotomy. So this is a characteristic thing. When we do ruminotomy in case of diaphragmatic hernia, this type of characteristic frothy contents will be seen. So that was one of the case. This is another case with the bloat. So recently purchased animal. This is one of the beautiful thing in diaphragmatic hernia. I noticed this. There will be abdominal contraction from lower to the upper end. From ventral to the dorsal end, there will be contraction of the rumen. We can see that the rumen is contracting like this from ventral to the dorsal aspect. In all the cases I found this. So when we do ruminotomy, this is frothy content which can be seen. So this surgery needs positive pressure ventilator. But under the field conditions, we can operate it since the mediastinum is closed. It is not complete in case of large ruminants. So if foreign body is at one thoracic cavity, one half of portion of the thoracic cavity, when we open, one may undergo collapse, but another lung will be functioning. So we can do the surgery. I attempted the surgery in this particular case with the diaphragmatic hernia. First we should do the ruminotomy. We should evacuate 100% of the contents of the rumen and reticulum. So there we can feel where is the hernia. We can easily feel the hernia from the after ruminotomy. So we should close the rumen, and on the next day we should ventrally open the abdomen. So here is the diaphragmatic hernia. So this is after herniorrhaphy. How to do herniorrhaphy? We should take silk or nylon material, long material. Blindly we should suture it by continuous lock stitch pattern. So this is how diaphragmatic hernia can be repaired, and from the ventral approach. So I did this surgery under the sedation with the xylazine and local anesthesia. So this is the recovered animal with the diaphragmatic hernia, and we operated around 3 animals. Up to today I got only 3 animals. So but in North Karnataka, so many field veterinarians are doing this with a good success rate, diaphragmatic herniorrhaphy. So this is the case which was recovered. So I just explained the movement. This is another case. We can see classical movement of the rumen. From ventral to the dorsal aspect there is contractions. We can clearly see from ventral to the dorsal aspect rumen is contracting. So if we visualize the animal, we should see for 5 minutes the left flank. There will be hypermotility during the diaphragmatic hernia. The same thing will be seen during vagal indigestion too. Only in these two cases there will be hypermotility of the rumen. So this is during the surgery. So here, this is after the surgery. We did diaphragmatic herniorrhaphy for this particular case too, and with general anesthesia we used propofol, a lower dosage. Along with the local anesthesia, we did the surgery. So coming to the vagal indigestion. Vagal indigestion is a complex condition. So it is not a separate condition. It may be a post effect of traumatic reticulitis, traumatic reticuloperitonitis, and diaphragmatic hernia. So by all these conditions, the reticulum will adhere to abdominal wall. So at the adhesions, there will be inflammation, and it will damage the vagal nerve. In turn, it will lead to vagal indigestion. So this was what vagal indigestion can be seen by two forms. One thing is hypomotility at the reticulo-omasal orifice. So because of this, due to hypomotility of the reticulo-omasal orifice, the food content will not move. Because of that, there will be bloat. So animal will look like papal-shaped abdomen. Papal-shaped abdomen means there will be left side, it will be just like apple. That will be that much swelling. Right side pear shape on the ventral abdomen. Both will give a look like papal shaped abdomen. So another thing is abomasal atony. Whenever there is vagal indigestion, abomasal content will not move. That may lead to abomasal impaction. So these are the two things where we will see during the vagal indigestion. So this is one case. This can occur by traumatic reticuloperitonitis, vagal nerve damage, or reticular adhesions. This is the papal shaped abdomen. Along the left side, apple shape, on the right side, that is pear shape. And the animal was passing pasty dung. This animal was operated. What can be done? We can do only we can assure that animal will recover. So we can go with the medical therapy by purgatives and antibiotics and nervine tonics. Either we can go for surgery. So here, after doing the surgery, we should flush the omasum. So in the last sessions, I explained in detail. I will just tell in brief. After doing the ruminotomy, once we entering the reticulum, we should search for the omasal opening. It will be at the 4 o'clock position of the reticulum. Only 2 fingers will be entered into the omasum. So we should take one pipe, and one end should be held in the hand. You should insert that pipe into the omasal orifice. Only 2 fingers will be going into the omasal orifice. Through that, we should pass the end of the pipe. Another end will be outside the body. So just I am doing the same procedure here. From that, we should infuse around 250 ml of warm water mixed with the 250 ml of any vegetable oil mixed with half liters of warm water. This is an important procedure. Whenever anyone doing the ruminotomy will feel the difference. So first, when we touch the reticulum, when we try to enter the omasum, we cannot enter the omasum. Only 2 fingers can be entered. But immediately after doing this procedure, that orifice will relax and we can easily enter the omasum. And if we go after entering the omasum, if we go ventrally, we will enter abomasum too. Cranial aspect of the abomasum we can enter by doing this procedure. So this is how we should flush the abomasum during vagal indigestion. Because of there will be abomasal atony, but only cranial portion of abomasum can be emptied by this procedure. So in this particular case, I took out the abomasum after closing the ruminotomy site from the left flank only. I opened abomasum and the contents were evacuated. This particular case recovered very well. And how I concluded it as vagal indigestion, I will come to that in the next slides. So this is how the abomasotomy was done and contents were evacuated. So this is the recovery. After 12 days, the animal recovered very well. So this is about vagal indigestion. So how can we diagnose it to the near to the perfection? The main thing is atropine test. So how to do, why to do? Atropine test, what is the thing is, whenever there is vagal indigestion, there will be bradycardia. Why there is bradycardia means that vagal nerve stimulates the heart, that will lead to bradycardia. So when we give atropine to the animal, that will vanishes the effect of this vagal nerve on the heart. So normally heart will start pumping. So whenever there is vagal indigestion, there will be bradycardia. When we give atropine, it vanishes the effect of vagal nerve. So heart will return to normal thing. There will be normal heartbeat. That means whenever there is bradycardia, when we give the atropine, the heart rate will become normal. That indicates that there is some involvement of the vagus nerve. So I will just explain this. So how much to give atropine? This vagal stimulation of the heart will be demolished by the atropine. So we should we should give any animal if it is suspected for vagal indigestion. So vagal mediated bradycardia abolishes by atropine and not by other causes. So we should give around 40 mg atropine. 1% solution should be given subcut. Whenever we suspect, we will get papal shaped abdomen, you just check the heart rate, there will be bradycardia, usually around 50-60 will be there. When we give, you should give atropine of around 40 mg subcutaneously, wait for 15 minutes, once again check the heart rate. If it is raised more than 16%, that is around 10 to 15, if it is raised the 12 to 15, then it indicates there is involvement of the vagal nerve. So by this we can conclude it as vagal indigestion. So okay, some other causes of bloat in animals. So coming to the other causes, peritonitis. So whenever there is diffused peritonitis, there may be bloat. So this was a case presented with the bilateral enlargement of the abdomen. So, and when even there was little rectal prolapse too. So diagnosis of peritonitis is very easy. This is caudal abdominocentesis. Just in front of the udder, just below the flank fold, inserting a needle, huge quantity of fluid indicates there is diffused peritonitis. Prognosis will be usually guarded in these particular cases. So this also leads to bloat. This is about one thing about generalized peritonitis. So this was an animal presented succussion. I am doing succussion on the left flank. This was an animal presented with a bloat. So I could feel clearly the fluid thrills. That indicates there is accumulation of the fluid. The prognosis is bit guarded. So since there is generalized peritonitis, I am getting huge sound when I did the succussion. So another causes are internal abscesses. In any organ, if there is abscess, because of ruminal atony, there will be bloat. So this was a case presented with recurrent bloat. And when I operated, I did ruminotomy, and there was no foreign body at all. I closed the abdomen. I searched for some other affections in the abdomen. I got abscess in the right dorsal aspect of the body. So there was a huge abscess. I inserted a Foley's catheter, evacuated everything, but even then this was a huge abscess on the dorsal abdomen which led to abscess. I recovered all the pus, around 2 liters of pus was evacuated and Foley's catheter was introduced, but even then after 10 days animal died. There was a huge tumor mass in the ventral region, and because of that there was abscesses, multiple abscesses in that. So this is during the postmortem. That means one internal abscesses also will lead to bloat. So this is another condition which leads to bloat, that is hydroallantois. Around in 7 to 8 months of pregnancy, we will get the cases with the bilateral enlargement of the abdomen. There will be severe dehydration. That is one of the signs which will be seen during the hydroallantois. This is a very late presented animal. This is another case of hydroallantois. We did aspiration, and at the left flank we found allantoic fluid. So animal will pass very small quantity of dung. By aspiration we found it as abdominal, that uterine content. So that is one thing. Another one thing, bloat by epimeral fever sequel. So this was a case presented to me with bloat and subcutaneous emphysema. Subcutaneous emphysema is one form of ephemeral fever, but that time I was not knowing that. The animal was in a severe, very severe state. It was feeling difficulty in breathing. I thought there may be some abdominal affection. I did ruminotomy wrongly for this particular case. After ruminotomy also there was emphysema, and animal recovered after 10 days. After that I referred so many books with teachers. I came to know that this was a case of epimeral fever. After that I treated more than 50 cases similarly, but at that time I was not knowing the epimeral fever also can lead to bloat. That is the thing happened. So you all maybe noticed that during epimeral fever there will be mild bloat. So this is the one thing. And other thing is, whenever there is ruminal impaction or omasal impaction with the huge foreign bodies, space occupying foreign bodies, that will lead to less ruminal microflora. That will lead to ruminal atony. Because of the huge accumulation of the content, there may be bloat. So such one case, a buffalo presented with not passing the dung. There was severe dehydration, and animal was not passing dung. The abdomen was looking like always complete. And during the ruminotomy, huge quantity of fluid gushing out through the left flank. So this much quantity was gushed out. This was a pregnant animal, gave birth to normal calf, and still now animal is living a happy life. So this occurred because of the omasal impaction where there was for phytobazars. So that led to bloat because of this impaction. So this case recovered nicely. So another thing is some misconceptions about the bloat. This was a video sent by my friend. He was telling that there is a enlargement on the left side. So this may be a case of left-sided displacement of abomasum. For clarification, he called me. So I told that this is not a case of left-sided displacement of abomasum. Why means in case of left-sided displacement of abomasum, there will be no bloat at all. Now one misconception I also had in me previously is whenever the left-sided displacement will be there, the abdomen looks bulged on the left side. This is wrong perception. The animal will be standing normally. The abdominal contour will also be normal. The abomasum will come onto the left abdominal wall. So rumen will be pushed to the right side. So when we view the left flank, it will like shallow. That is, it appears like animal not at all taken anything since a week. Like that, the abdomen will be shallow, not bulged, opposite to the bulging. That will be there during the left-sided displacement of abomasum, and this may be other cause. So during left-sided displacement of abomasum, there will be shallow appearance of the left abdominal wall. In the last sessions of the Lava TN, I explained clearly about LDA and RDA. We can go through the YouTube link of Lava TN and we can clearly known about the LDA. So like this, simultaneous auscultation and percussion should be done. By this, to the near to the 100%, we can diagnose left-sided displacement of abomasum. So by simultaneous auscultation percussion, we will get clear ping sound of abomasum. So here the same animal during the surgery, so we can see the abomasum which is displaced to the left side. This animal recovered very well. Till today, it's giving around 15 liters of milk per day. It was reduced to 2 liters per day. Now it is recovered very well. This is a left-sided displacement of abomasum. So up to till now, I explained about different causes of bloat. In another 5 minutes, I will explain about different methods of ruminotomy. So different methods of ruminotomy are, under field conditions, we can opt any type of ruminotomy procedure, any type of procedures. So there are 3 methods to do the ruminotomy: rumen skin suturing fixation, Weingars ruminotomy set, or using the cuff. So anesthesia, sedation if necessary. Already I explained yesterday, we can go with the BXK combination, that is buterphenol, xylazine, ketamine, at the dose rate of 0.01, 0.02, 0.04 milligram per kg body weight, taken in a single syringe. It should be given subcutaneously or intramuscularly. This is BXK combination. If needed, it can be given. Usually I do ruminotomy only with the nerve blocks. I sedate the animal only if it is needed. I usually will not do the nerve blocks. And inverted L block and paravertebral nerve block, both I will do for doing the ruminotomy. So even these procedures are also I explained in the last sessions. So you can go with the YouTube link and where they explained all the procedures of the anesthesia. Now I will just go little faster. It is inverted L block and rumen skin suturing fixation. This can be done at the emergency conditions. When we get a bloat case, emergency, we can open the skin, muscles, we enter. This is the rumen. Rumen should be fixed to the skin. So we should start suturing from the 3 o'clock position. Just like simple continuous pattern, we should come up to this one, 9 o'clock position. You close, you put a knot here. Once again, you start and suture the rumen to the skin up to here. So this is the rumen skin suturing fixation. After that, you can give incision and do the ruminotomy. So this method having advantages and disadvantages too. So what is the advantages is this is very cheap. Without any instrument, we can go with the surgery. So in emergency conditions, this will definitely help. This is economical and there is less chance of leakage of the content into the peritoneum if we do the fixation properly. So but disadvantages is it is time consuming to suture the rumen to the abdominal wall. Whenever sometimes if we are not doing it properly, it may rupture or tear. The sutures may tear at some spots that may lead to leakage of the content. So wound dehiscence at the surgical site is another complication. Since we are suturing the rumen to the abdominal wall, the content which we are evacuating, they will touch the skin. So that may lead to wound dehiscence. So another thing is doing ruminotomy with the Weingars ruminotomy set, which is regularly using in all the veterinary colleges. So this is what happens when we do the rumen skin suturing fixation. There is a lot of quantity of ruminal content came out. After the recovery, after 30 days, the rumen adhered here and there was wound dehiscence. We can see the ruminal movement inside the content was visible. So I did once again sutured it, and once again daily flushing of the abdomen was done and the animal recovered very well. That is the one of the complication when we do rumen skin suturing fixation. Even though if we do any aseptically, sometimes some complications may arise. So that is about that. This is the Weingars ruminotomy set. The frames will be available and we should fix it. And the advantages with this method is whenever there is plastic or resin materials, you will be coiling and huge quantity will be there. So removing them through the rumen skin suturing, if we perform this only this much opening, it is tough. So even though if we use cuff, then removing the content is tough. But when we do this, we can extend the incision and we can remove huge quantity of plastic materials. So that is the wide opened area. We can, this is in this there will be more access to into the ruminal wall. So that much huge opening will be there. We can easily do the procedures when we use this. But the disadvantage is when we are evacuating the content, sometimes the clamps may be loosened and they will enter the abdomen. That only one thing that may happen. So that should be taken care. That should be held by the assistant. That is only the negative thing with this. And coming to the rumen cuff, this is one which is I am regularly using. So we can do the confidently, we can do the ruminotomy with this cuff. So this cuff is available. So after giving anesthesia, always do the surgery in the standing position without tying animal to the anything. We should take the animal to the open field and we should do the surgery. So after giving the skin incision, we enter the abdomen, take the rumen out, give a neck incision and place the cuff and do the procedure. So that is a simple thing about ruminotomy. But in any method of ruminotomy, one thing should be kept in mind is the content of the rumen should not enter the peritoneum. If we take care that, there will be 100% recovery. If we found the cause, there will be 100% animal will recover. The peritoneal content should not, that ruminal content should not enter the peritoneum. So here, after giving an incision, I am placing the cuff. So this cuff should be placed into the rumen. Like this, we unfold it and we will apply the bandage. So this is the bandage. If anyone needs, I will share the video with you. So like this, we should do, and after this we can evacuate the contents. So after doing this, while suturing, the frames will be supplied along with this cuff. Frames can be applied and suture can be applied. So advantages is the chances of leakage of content into the peritoneum is very less, and very less assistance is needed. Asepsis can be maintained very well, but tough to remove the large foreign bodies through this. That is the only negative thing with this. And during surgery, what should be followed during the ruminotomy? We should frequently change the gloves. Once we are doing ruminotomy, once we touch the ruminal content, with the same hand we should not touch the outer end of the rumen and skin and muscles. We should change it. That is the one thing. When we don't insert hand into the abdomen after performing the ruminotomy, unless it is recommended. It is very much needed. So after doing the after opening the abdomen only, we should search entire the abdominal cavity. Just opening the muscles before opening the rumen, if we insert our hand, we can check for the reticular adhesions. We can clearly tell whether there is adhesions or not. After that only we can enter the abdomen. So after doing the ruminotomy, we should not enter once again. So that is the thing. And use normal saline if peritonitis is suspected. I already explained it. So normally evacuate 60% of the content. So if there is acidosis or diaphragmatic hernia, then only as much as possible all the content should be evacuated. So in some cases where we evacuate all the content, we can replace some portion of cud. So how to approach the esophagus during the ruminotomy? I already explained it. So after opening from the rumen, when we enter the reticulum at that spot, in the rumen itself, at the 2 o'clock position, we will feel one mucous membrane like structure. We can enter 2 fingers into it. That is the esophageal opening. How to approach the reticulum? Just from the rumen, if we move our hand cranially, we will feel the honeycomb structures. That is the reticulum. So we can palpate each and every honeycomb structures. So in this animal, only this tip was available in the reticulum. So while feeling, I felt it, I removed it. So approaching the omesum, already I explained. So at the 4 o'clock position of the reticulum, there will be omesal opening. So we should pull the reticulum. We will easily find that omesal opening. We should pass a pipe and we should infuse it with the 250 ml of any vegetable oil mixed with warm water. After that we can enter completely into the omesum. After entering the omesum, if we go ventrally, we will feel mucous membrane like structure. That is the abomesum. So that is the approach to the abomesum. So this is how we should flush the omesum and abomesum. Okay, this is how we should flush the omesum. So I am inserting one pipe and flushing it with the normal saline. And by this suture, coming to the suture materials, under the field conditions, catgut number 2. Okay, we always use double layer suturing for the rumen. And okay sir, okay sir, I will go. Okay, coming to suturing materials, suture catgut number 2 is economical, which I am using regularly under the field conditions, but the best one is polyglycolic acid or polyglactin 910. So that can be used, but since it is economical, I am always using catgut number 2 without any complications. I am practicing it. And coming to the muscles, catgut number 2 can be used if we are having polyglycolic acid or polyglactin 910. Number 2 that can also be used. For the skin, any non-absorbable sutures can be used. And this is about the suture materials. And pattern, always we should suture the rumen by 2 layers, any 2 layers, Lambert, Cushing's, we can club both or do the same for the 2 times, we can follow anything, but 2 layers should be done. For the muscle, simple interrupted or simple continuous. I always do simple continuous pattern with I will place 3 or 4 simple interrupted also. So coming to the skin is simple interrupted, anything simple interrupted, horizontal matters, vertical matters pattern can be used during the ruminotomy. So Lambert pattern, this is the Lambert pattern where after suturing some suture materials will be visible, but in Cushing's pattern we will not see the suture materials. This is just for the knowing how what is that. So suture removal usually 12 to 15 days. Post-operatively, antibiotic and anti-inflammatories should be given for 5 days. If we are suspecting peritonitis, it can be extended up to 15 days. So regular cleaning of food and cleaning of dressing of the wound should be there. So some complications may arise after the ruminotomy. I already explained. That is, this is one case of traumatic reticuloperitonitis I operated. But after that, there was doing ballotment. There was fluid accumulation on the ventral abdomen. Even though aseptic precautions were taken care, but there was development of peritonitis in this particular case. So just I diagnosed it by inserting 1 2 ml syringe. So there is a fluid accumulated. So I placed one Foley's catheter into the abdomen and removed around more than 12 liters of peritoneal fluid. Foul smelling fluid was accumulated. So complete bucket full of fluid was evacuated from it, and antibiotics were given for 15 days. I flushed with the normal saline. This is after recovery. So this was operated around 4 years back. Still now animal is doing very well. So I am very much thankful to all my teachers, friends from my college days, all the teachers, and from the WhatsApp groups and from the webinars, from the seminars, and every teachers gave me insights to do surgeries under the field conditions. My second topic about cesarean section, I will try to cover it as early as possible because of the time constraint. Okay, how to increase the survivability of the after cesarean in large ruminants. So unlike in humans, what we face on the vets we face is there will be always delayed presentation for the animal, for the surgeons. So many the farmer wants somehow that calf should be removed from the dam. That is the thing. So many will be handling. After that, when animal goes to recumbency or whenever there is calf is dead and emphysematous only, the cases will be referred to the surgeons. So when animal is presented to us, the animal will be in shock and already it will be under toxemia, and there will be severe pain of the animal because of the huge handling. So that is the thing, we should keep it in mind, unlike in humans where they will decide the cesarean before onset of pain itself. So there will be 100% recovery. But here it's not been the case. Surviving an animal after cesarean is a challenging task in veterinary field. So what should be done to increase the survivability? That is, the one thing is, first we should stabilize the patient before attempting. Whenever we get a case like this, we will be getting the cases. The animal will be in lateral recumbency. There will be swollen vulva, so it will be bloat, animal will be struggling, there will be severe pain, whole vulval region will be swollen, animal will be under severe stress. So first we should put one trocar and cannula. Even that needles yesterday I showed, that also can be used to remove the gas. So this is another case presented with a severe bloat. After so many handling, only these animals will be referred to us. So this case with the severe vulval edema, so there was a little rectal prolapse too. So first we should evacuate the gas. That is the primary thing first we do whenever we get case with the bloat. After evacuating, these animals should be, this is a presentation of the another animal. This was laid on the, just like it was in a dead condition, comatose condition. This was presented to me like this, just beside the road, just like animal was, when I went there, I felt that the animal is already dead. Like this, it was presented with the swollen rectum, vulva. There was severe handling. Somehow they want the calf should be removed. That is the problem. So this is another case with the swollen vulva and rectum, everything. So like this, when the cases are presented, first we should stabilize the animal with the fluid therapy. First we should give any anti-inflammatory. I always give 1 shot of dexamethasone when the animal is presented to me. After that, I will infuse the fluids, preferably DNS. This, why should we give the fluids? This is for taking the animal out of the toxemia. Minimum 2 to 3 liters of fluid should be given. Then epidural anesthesia. Once I reach the spot, before attending, I will give epidural anesthesia. So how to give the epidural anesthesia? Everyone is knowing, I am just explaining for the freshers. You lift the tail like this. So the sacrococcygeal junction will be there. This is the first intercoccygeal space. That is wider in case of cattle. First intercoccygeal space. So there apply the spirit and you insert the needle. Just 5 ml of anesthetic is enough. Don't give not more than that. Just 5 ml is enough. So insert the needle at 45-degree angle. So I am not pushing the needle completely. We can see some gap is there between the skin and needle. Around only one inch if we enter, we will be there in the epidural cavity. There is need not to push complete needle into the epidural cavity. If we push it, then if it is freely flowing, it is the epidural space. Just 5 ml is enough, so that the whole perineal region animal will be free of pain. This is the very much needed procedure once we reach the spot. So different approaches for the cesarean. When we went there, we did fluid therapy, we gave anti-inflammatories, we did epidural anesthesia. After that, deciding for the surgery. Surgery can be done by in the recumbency or in the standing position, by left or right side. And we should decide based on the case whether to do surgery in recumbency or in the standing position. When to do, I will explain. Okay. So when we take the animal to the recumbency, we should always be cautious about radial nerve paralysis in any surgeries. So here I took the animal to the right lateral recumbency. So here I use straw as the bedding material for the forelimb. So radial nerve will go very superficially at the musculospiral groove. So while performing any surgeries in the lateral recumbency, even it is a 5-minute procedure, take care of this. Though there is need not to give complete bedding, we should give bedding at the that portion at the musculospiral groove, that is the humerus region. So always it should be taken care that there should be sufficient bedding. So this is the one thing. So even then, after taking care, so many animals will go for the radial nerve paralysis. In this particular case, there was no much assistance. I always refer one assistant for this procedure. This only. You should always look in that whole area is covered with the bedding. Even then, in this particular case, after surgery, this was a case referred for cesarean with a schistosomus reflexus calf. I did the surgery. After that, the animal is not putting the weight on the right forelimb. This is a classical case of radial nerve paralysis. So usually this will recover. So this animal recovered very well in 2 to 3 days. So then coming to the incisions, oblique incision below the flank fold. This is the flank fold. So just below the flank fold, giving a oblique incision. This is very much comfortable for me. So many surgeons will prefer their own methods. This is one of the method, oblique incision just below the flank fold. By this we can remove the dead and emphysematous calf easily. So after but in buffaloes doing this is tough. This is my field. Since in buffaloes this milk vein will go like this, so this will hinder the surgical side. But in cattle we can go with this. This is also called as modified Young's approach. So this is one method of doing incision, and this is another one. We can even give the incision in the oblique fashion just above the flank fold. This is the thing. We incising the abdomen just above the flank fold. This is another approach. So in this particular case, we did above the flank fold. So depending on the surgeon's opinion choice, we can go with these two approaches in the recumbency. But even then, we can go for the standing position. This is very comfortable for the surgeon. But when to do, I will just explain. Oblique incision from tubercocce to the last rib. This is very comfortable position in the standing position. From the tubercocce up to the last rib, oblique. This is another standing position. The straight incision in the flank region. I will just straight incision in the caudal flank. This is another approach for the standing approach. So these two are the standing approaches, and remaining I showed are the recumbency approaches. In this particular case, I did cesarean in the sternal recumbency. Since I prepared the animal for standing position, but animal went to recumbency, so I did this procedure in the sternal recumbency only. So we can do surgeries in all the positions, but the main thing is always you should use the drape. Peritoneal uterine content should not enter the abdominal cavity. That should be taken care. So decision should be taken based upon the animal condition. So what decision should be taken means the standing position, standing cesarean should be done only when the calf is live. If calf is dead and emphysematous, don't go for standing surgery, since we are pulling the uterus to the flank. If it is calf is dead and emphysematous, we cannot pull it to the flank. That is the problem. If the calf is live, sometimes some anatomical abnormalities will be there. Sometimes the calf will be live, but cervix is not dilated. So when we opt for cesarean, we can go with the standing method. Otherwise, you go the recumbency. So we can palpate it. Where we will get some fetal parts, we can decide. So in this particular case, I am palpating. So I am getting some big fetal parts in this area. So I am going for this approach. So that is incision on the just ventral to the flank fold. So sometimes if we get calf in the upper area, we can go for that. Coming to the anesthesia, when we are doing standing cesarean, we can go with the this is caudal epidural anesthesia. If needed, you can take it. Or systemic sedation. If animal is in severe pain, we can go for systemic sedation. Already I explained about BFK combination. Step 3 is local infiltration. Majority of the cesarean under field condition in the lateral recumbency, we will do with the local infiltration. So if in the standing position, we can go with the paravertebral nerve block along with the inverted L block. So this is the local infiltration, giving anesthesia to the skin and next to the muscles. So from here. So whatever the incision area is there, giving in anesthesia infiltration. So I usually do surgeries of this usually with the caudal epidural nerve block I already given when I visited the spot. Then with the local infiltration only I will do the cesarean for recumbency. For standing position I will go with this. This is the paravertebral nerve block along with the inverted L block. So this is the last rib and this is the lumbar vertebrae, transverse process of lumbar vertebrae 1, 2 and 3. So this is the last rib. This is the Ferguson's method of paravertebral nerve block. So this is the first transverse process of lumbar vertebrae. You should identify the cranial aspect of this first transverse process of lumbar vertebrae, and around 5 centimeters away from the midline you locate this spot, and there you give 2 ml of local anesthetic to the skin first. So I am doing that. I am locating the first in the transverse process of lumbar vertebrae. This is the L1. So here we are blocking T13 nerve. So I am just identifying the cranial border. So there I am giving 2 ml of local anesthetic to the skin first. So similarly I will give 2 ml local anesthetic to the in front of L2 and then in front of L3. So this is about Ferguson's method of paravertebral nerve block. First just giving to the skin. To introduce a long needle, we are preparing the site with the infiltration of only 2 ml of anesthetics. So after giving this, you take the 6-inch spinal needle, stainless needle. It is available as spinal needle everywhere. See, 18 gauge will be optimum. So taking the 18 gauge needle at the cranial border of L1, I am inserting the needle at the 90-degree angle. So when we are pushing, it will enter into a slit. We will feel one sound there. Otherwise, we will feel with the hand. So there you insert the needle and push around 10 ml of anesthetics. Just pull it for another 1 to 2 centimeters. Once again you give, so that we are blocking both the dorsal and ventral branches of the spinal nerves. So I am holding it around 3 fingers. This is the distance usually we will get that slit. There we can enter and we can give 10 ml of anesthetic. So we can practice in every cases. By that we will become very easily we can do the procedure. So around 10 ml is given. After that I am withdrawing the needle upwards around 2 to 3 centimeters. Once again I am giving anesthesia just to block the dorsal branch of the spinal nerve. So I am giving another 5 ml of anesthesia here. Similarly, like this, the same procedure should be repeated on in front of the L2 and L3. So I will just skip it. I will share the videos if anyone needed. So this is about Ferguson's method of nerve block. This is Magda's method. This can be done easily without any confusions. So here we need only normal 1.5 inch needle is enough. No spinal needles are required. So I am showing on the right side. So here you identify L1, L2 and L4, not the L3 for Magda's. That should be kept in mind. L1, L2, L4, not the L3. So just identify the transverse process of lumbar vertebrae, give 10 ml anesthetic on the dorsal aspect of the lumbar vertebrae and 10 ml on the ventral aspect of the lumbar vertebrae. Similarly, the same procedure should be repeated on L2 and L4. So now I am blocking dorsal branch of the T13 nerve at the lumbar vertebrae 1, L1. So on the ventral aspect also 10 ml is given. So this is over. Similarly, the same procedure should be repeated on the L2 and L4. This is about Magda's method of paravertebral nerve block. So after along with this, I will do inverted L block too. So with that, I will go for the surgery. So then preoperative antibiotic and whenever I go for the surgeries, any surgery, as soon as I enter the place, I will give the antibiotic. After that, I will prepare the animal. So it will take another 30 minutes to 1 hour to start the surgery. By that time, the antibiotic concentration should be there at the surgical site. This will prevent the post-operative complications. In all the surgeries, we should give preoperatively the antibiotics and anti-inflammatories. That is the prerequisite for preventing the post-operative complications. So thorough scrubbing should be done, application of antiseptic should be done, and in recumbency, skin incision, muscles, then peritoneum. After entering the abdomen, during Cesarean, we will give skin incision, then to the muscles, then to the peritoneum, we will enter the abdomen. In recumbency, when we are doing, once we enter the abdomen, so will be momentum will hinder our exposure to uterus. So we should just pull it to the cranial side, pass your hand, hold some part of the calf and bring it to the operative site. This is the main prerequisite in any surgery, that any portion of the calf should be taken out along with this uterus like this outside. So why this is very important is, by doing this procedure, when we give incision on this, all the infected contents will come out. These infected contents should not enter the abdomen. There lies the success rate of the cesarean. All the content should come out, not into the body. In humans, they may not doing this procedure, since there will be no one is handling from the outside. They will decide the surgery and they will do. They can incise in the abdomen itself. Nothing will happen since uterine fluid is sterile. But in veterinary practice, after handling by so many, there will be infected contents. So these should not enter into the abdomen. So this is the main procedure of taking uterus to the outside of the body. We should place the drapes like this. We should take it into the inside, so that when I give the incision, all the content should come out. I always tell my assistant or my fellow colleagues to hold the uterus. His job is only to hold the uterus. When someone is pulling the calf out, his job is only to hold the uterus. As soon as calf is coming out, he should pull the uterus out, so that the content should come out. There lies the success rate after the surgery. So this is how we should drape the animal, drape the uterus before giving the incision. So like this, some part of the calf should be taken out, then it should be draped. After that, incision should be given. Always give the incision from ovarian end to the cervical end. Why this should be done is, when we start giving incision from the cervical end, accidentally we may touch the ovaries. There will be ovaries will be lying, and if we damage the ovary, future conception will be hampering. So always give the incision from ovarian end to the cervical end. While suturing, this is opposite. So while suturing, this is opposite. That is, suturing should be started from the cervical end. We should come to the ovarian end. Why this should be done is, there will be pulling pressure at the cervix. The uterus will be attached to the body at the cervical region. It will be hanging. So when we start suturing from the cervical end, it will be normal. If we start suturing from the ovarian end, we are suturing, but it is tearing towards the cervical end because of the pressure. Always start suturing from the cervical end to the ovarian end. So that is another thing of suturing the uterus. So 2 layers of suturing should be followed in every case. That is, any 2 methods, Cushing's or Lambert, anything that can be clubbed, but you always give 2 layers of suturing. This is Cushing's method, where we cannot see the suture material. So next is Lambert method. Anything can be clubbed. In Lambert, more suture is required, more inversion will be there. We can see the suture materials outside. So coming to this muscle, similar to the ruminotomy, 2 layers, simple interrupted or continuous lock stitch can be used. Subcutaneous layer, if needed, that can be given. Otherwise, it can be skipped, and directly we can go for the skin suturing. So this is about the suturing, and for the skin, any non-absorbable sutures can be used. So this is about skin suturing. Any non-absorbable matter, any method can be gone for the skin suturing. So another thing is, immediately after surgery, we should make the animal to stand. and we should massage the limb from down to upwards. Why this should be done? The animal will be in recumbency from the whole day when we go to the spot. The whole muscles will be under tension. The animal will not able to rise after the surgery if you leave like that. It may go into recumbency. Down or cow syndrome may happen. We should make the animal to rise. After that, we should massage from the bottom to the up in the upside direction. We should massage all the limbs. So this will lead to more success after the surgery. Sir, in the direction of veins, we should always massage any part of the body in the direction of venous flow. Always massaging should be done like this only, sir. So like this, massaging should be done from the down to the upwards of the body. So this is how we should make the animal to stand. And like this animal was presented. So we did surgery, and this is a beautiful case. When we do the surgery aseptically, the results will be wonderful. This owner was a drunkard. He, after the surgery, he tied the animal somewhere and he went. I told it was a long way to me. I went there, did the surgery, and the next day I consulted the paravet there, and he went there, but he was locked the door and went. The owner didn't approach anyone after the surgery. But somehow he gave antibiotic for 1 day. After that, he also not gone paravet. After 12 days, the animal recovered without any complication, without any antibiotic. The animal recovered. So that is the beauty. When we do the surgery aseptically, the animals will recover wonderfully. So this is how the animal recovered. So post-operatively, minimum antibiotic for 5 days. If we suspect any peritonitis, then it should be continued. So in standing position, how to do the surgery, I will go with this in a few minutes. So any part of the calf should be taken out after giving the incision. Like this, we should apply the drape. Any part of the calf should be taken to the left flank. Here I gave one incision obliquely. So similar to the recommended pattern, we should always use we should avoid the cotyledons. If they are on the way, we should avoid it, otherwise there will be bleeding. So after giving the incision, taking the calf out with holding the uterus. Like this, calf is taken out. This is standing position, standing cesarean. Calf is taken out. So this is another case with the recovery after doing the standing method of cesarean. So this is another case. We cannot identify the suture site itself. That's the beauty of suturing in this particular case. Some complications, how to tackle them. When we doing the surgery, uterine rupture is one of the complicated thing which will lead to death of the animal after the surgery. Sometimes we do the cesarean, after 20 days animal may die. Why means, while handling, because of the hooks or some excess pressure, the uterus may tear. All the contents may enter the abdomen. So while performing cesarean, I spotted these two things. In such circumstances, we should lavage the abdomen after the suturing the uterus. This is one of the case with the uterine torsion attended by other vets. So I did it in standing position, but when I incised, the calf was there in the abdomen, outside the uterus. Already uterus was torn. So that was a case, was very guarded one. So we flushed it. Myself and my wife operated this case in the night. So here we flushed it. So with the ample quantity of normal saline, and in the standing position we did the surgery. And after that, in order to evacuate the contents, I placed one Foley's catheter on the ventral abdomen. So this case, this is like this, and I used RO water around 30 liters for lavaging the abdomen, since already the infected content entered the abdomen. So we used RO water sufficiently. So in order to take it out, I placed one Foley's catheter onto the ventral abdomen. I will just show how I placed it. So from the ventral abdomen, okay, I not included that. Okay, this is after recovery. After around 2 months, the animal recovered very well, and the same animal happily living. So that is the one thing. And another complications during the surgery is wound dehiscence. Sometimes, even though if you take any care, some content will be touching the skin. So in this particular case, there was wound dehiscence after the surgery. So that was that can be tackled easily, but it will take more time to heal. That's all. So fluid accumulation at the surgical site. So this is another case with the wound dehiscence, and this animals also recovered. This is another case with the wound dehiscence. So this should be small one suture should be removed. All the content should be evacuated. Just like abscess, how we were treating, we should tackle these type of cases. So this is a case where there was standing cesarean was done, and there was accumulation of pus. And second complication is peritonitis. So sometimes peritonitis may also develop, and cases should be long-term antibiotics can be given. So some special presentation is this case was a cystosomus refluxus. It was presented in the night, and we did the surgery with only one artery forceps was had. I had only one artery forceps at that time, but it was an emergency condition. We did the surgery, but animal recovered very well with the wound dehiscence, but animal recovered very well. So like that, so many cases are there, but this is how the Foley's catheter was introduced onto the ventral abdomen. So this is the animal after surgery, and this is how the animal is recovered. So this was a case of uterine rupture. So there I am using RO water to flush the abdomen. So this case also recovered very well without any complications. So this is about all the cesarean. Only one thing is right-sided cesarean. In only one case I did right-sided cesarean section. This was a case of post-cervical uterine torsion. So there was the animal complaint was the attended wet for 3 days, but it was not diagnosed as calf dead and emphysematous. So this was right-sided swelling was there. Only history by the owner is right side of the abdomen is swollen. Animal is not at all eating anything, and there was wry neck too because of the excess use of isoflux. So the right side of the abdomen was swollen. When I went there, the animal was in recumbency. So it was counting the last stages of her life. So I did plan for surgery. I decided to do it on the right side. Since the calf is on the right side, when we do parectal examination, calf is on the right side, it is dead and emphysematous. If we open on the left side, pulling it to the left side will be difficult, since the uterus size is very much huge and it is bloated. So I did it in the right side, ventral abdominal approach, and the animal recovered very well. Even and then the owner was treating for the hypokalemia, and this is after the surgery. And by all this, I am closing my session, and I am very much thankful to Lava TN for giving me a wonderful opportunity to interact with you all. Thank you all.